kind of loud, but little. And I just want to thank you all for joining us today. WellMed Charitable Foundation Caregiver Teleconnection Series. Today is a very special presentation by Dr. Nestor Praderio, who is a geropsychiatrist, one of the few that we have in the country, given our 30 million seniors, or maybe it's 35 million now. And it's about dementia versus Alzheimer's disease. How do you tell the difference? And Dr. Praderio, thank you so much. I'm so honored, that you take the time to come and talk to our caregivers.
Thank you, Elaine. Good morning. Thinking about how to initiate the year, we decide with my group and here with a face-to-face team and SOS caregiver. We will start discussing a subject that appear to be all in the concept, but this resurface every day with the same question. Is my mother or father having dementia, Dr. P, or they are having Alzheimer's disease? And it's an overlapping confusion, and they struggle to the point that some individuals get involved in arguments about, I told you that she have dementia versus it's not dementia, it's Alzheimer. Therefore, today we are going to chat a little about if we end up our morning capable to tell the difference. And with this, be able to correct others about these issues. And telling the difference, dementia and Alzheimer's disease separated are perhaps two of the most confusing diseases that exist around the realm of mental degradation, meaning cognitive disorder. When we open the chapter of cognitive dysfunction, those issues appear on the surface, and we have to be careful not to confuse them. The term dementia is to describe a set of symptoms and cover several disorders. The term dementia is building a package of symptoms. But then those symptoms can be provoked by several dementias with difference. Might be a vascular dementia, a Lewy body dementia, frontotemporal dementia, Parkinson's disease, and Alzheimer's disease. Therefore, dementia is this collection of symptoms of a neurological disorder. This is chronic and is gradually deteriorating the brain functions. This is dementia. Therefore, after you define dementia, you may say dementia Alzheimer type, vascular type, Parkinson's disease, Lewy body dementia, and name several other dementias, but separating what is the term dementia and what are the dysfunctions by disease. Therefore, when we say it's a dementia Alzheimer type, Marianne, I touched something again. Uh, let me just for a second. Thank you.
Thanks, Marianne.
You're welcome.
Well, I'm sorry for this lapse. Therefore, when we say dementia Alzheimer type, we are talking about the characteristics that describe the disease, Alzheimer disease. When we talk about vascular, with the characteristic of the type of dementia, the same for Lewy body or for Parkinson dementia. When we want to specify what is Alzheimer's disease, it's a group of a specific set of symptoms. When individuals have an Alzheimer's disease, the neurons on the brain start dying slowly because they are deposit of plaque, tangles, and the pathology of those areas deteriorate. Remember this, Alzheimer is the most common dementias. Between 65 to 70% of the dementia nowadays are Alzheimer type. Therefore, to close this differentiation between dementia and what is Alzheimer disease, Alzheimer is a form of dementia, but not all the dementia is caused by Alzheimer's disease. Therefore, clear, dementia is a syndrome, neurological syndrome describing symptoms. One of the most common is memory loss. And in here we have the type of dementia. And the most common in the United States is Alzheimer's disease. If we compare the two diseases, the onset of the illness, Alzheimer's disease has a hereditary form that can occur, the beginning of the disease can occur as early as 45 years of age. One of the characteristics of the hereditary form, familiar form of Alzheimer's, it have an onset disease very early in life. When on the other hand, the general dementia terminology in onset is usually late in life, appear 65, older, 70, 80, because one of the risk factors is aging. And the most that we age is the higher the probability for the disease to occur. Another way to compare is to realize that dementia is a medical term used to describe a number of conditions, but specifically, like I said before to you, gradual loss of intellectual function. There are some decreased motor skill, characteristic in a moderate stage of dementia. Increased language difficulties that we always discuss. The most common are receptive aphasias and word-finding difficulties, and disturbance of the ability to plan and execute. That is dementia with disturbance in the rational decision phase, with poor judgment, with lack of attention, with difficulties to accommodate and process an issue and being able to execute it and to move ahead with. Therefore, this is very important. Comparing the two, we need to have an idea of characteristic of the illness. There is a dementia that is often confused with Alzheimer's disease. And remember, it's a vascular dementia. Vascular dementia can be provoked by single stroke, poor circulation of blood in areas of the brain, multi-infarct of the brain, in which one there are a small side stroke spread in areas of the brain. But they have similarity with the Alzheimer's disease, with symptoms. The confusion is very similar. The short-term memory, wandering, the getting lost in familiar places, the lack of control for bladder and bowel, and other emotional problems, including some associated symptoms of depression. They are very similar. When Alzheimer and vascular depart and they differentiate, and we need to be careful, is how is the line of deterioration of one and another. Imagine this Alzheimer's disease decline through the years in a steady line, when vascular dementia have a line that goes down, up, down, up, a little up, a little down, and is more disorganized, and at the end, probably a little shorter in the years of disease compared with Alzheimer. But where are you? Okay. We are going now to understand these discussions and to have some value in differentiating this common question. We need to start with the diagnosis and to know that there are different types of dementia. For example, we talk about vascular. Let's talk about now about peak disease. This in general, now in clinical forums, you are not going to hear very much people talking about peak disease because they will name it frontotemporal dementia with atrophy of the frontotemporal areas, specific behaviors associated with this disorder is an early onset. Individuals have psychomotor agitation, they pace around, they can become a little more aggressive and disorganized. They have difficulties with executive function, and specifically, they function very poorly in social placement because they speak and they talk and they make comment. These are very disengaged with the reality and sometimes become very provocative. It's interesting. They have a visual memory better than Alzheimer's disease. They look at and recognize things. I always share with you this. One of my frontotemporal patients, frontotemporal dementia patients, an inpatient setting, left the unit. This is a lock unit with a code and very well supervised by the members of the team. And they found my patient in the parking lot. Security found her on the parking lot. And she went down 7th floor on the hospital. The elevator was ready to leave. And we brought her and we talked and we have a meeting. I brought her to the unit. She was very happy, like nothing happened. And the process of having an understanding as a director of the unit, an understanding what's happening here, I sit down with her and we start chatting about how she left the unit. And cross my mind is one of the team members didn't pay attention and she came behind one of them. And she said, clearly, no, I left the unit. I just left the unit. And how you did to leave the unit? Through the door. And how you open the door? Oh, you punch the code. You punch the code. And can you take me to the door and to do that? Yeah, she went there and punched the code. We all have. But Karen, where do you get the code? Oh, I just look at the nurse when they punch the code. And that was the frontotemporal dementia Karen, who in other case will be other type of Alzheimer's disease, on other type of individual with different dementia won't have the specific recall and visual activity. And we continue moving. Then we have Lewy body dementia. Entity, they have in certain form similarity with Parkinson dementia. Partially agitated, with up and downs, with very poor response to medications, specifically antipsychotic medications, and with very difficult, with mood instability, These are the patients that you interview them in the morning, and they are doing well. By noontime, they are extremely confused that you don't believe these were the same patients. And they agitate, they have difficult night sleep, and they are very difficult to manage on the behavioral component. We have Parkinson dementia. This Parkinson dementia is complex, is an associated neurological disorder of Parkinson's disease and the cognitive form of presentation. Parkinson have psychiatric components. This is depression, psychosis, and dementia. And the three occur successively and impact very much in the life of Parkinson's disease patients. We may have dementia for chronic use of alcohol, the old Korsakoff syndrome. It was described in Russia clinical setting. We have dementia for hypovitaminosis, lack of vitamin. The most common one is vitamin B12. Occur with more frequency south of us and here, specifically in areas of Central America, with some nutritional deficit and lack of vitamin B12. Tenemos head traumas dementia. This now we are studying, researching, and paying much attention is what we see and witness with individuals. They play soccer and they play football, both of them with constant traumas of the brain, and the product of this chronicity create the demented process. And we continue in order to see that there is more than Alzheimer's disease to have dementia. We talk about the vascular dementia, and specifically heart conditions create problems with dementia because they may have mini stroke or they have just a big stroke. We talk about the deficiency of vitamin. We talk about the chronicity of depressive episode, in which one individuals compromise the cognitive functions, and we have reaction to medications that create cognitive dysfunction that are similar to the demented process, but if we act accordingly, we can have resolution by a good adjustment of the medication. Well, let's conclude about this differentiation between them, what is dementia and what is Alzheimer's disease. Whether an individual's dementia is caused by Alzheimer's or other condition, it's very important to seek help and receive a proper diagnosis. Many of us question ourselves sometimes, asking why we need such a rapid diagnosis when we don't have a curative agent. when we don't have treatment, this will cure the disease? Well, the answer is because you can develop a consistent treatment plan in which one you accommodate many things in order to add quality of life to those individuals with the disease. At the same time, you facilitate, educate, and support family members of caregiver, because the role of caregiving, familiar or professional, is very difficult. Therefore, we continue supporting. This is important to seek help and receive a proper diagnosis early during the process. And remember what we talked today. Dementia is not a disease, but rather a group of symptoms characterized by decline in intellectual function, is severe enough to interfere with daily activities and with social function. That will be the criteria to give the name of dementia. Remember that the most common, from 65 to 70% of the cases, is Alzheimer's disease. It's followed by 17 to 18% of the cases of vascular dementia. And then we have Lewy body dementia, Parkinson dementia, head trauma dementia, neurological cognitive disorder secondary to syphilis. And we have dementia secondary to multiple sclerosis. And we have frontotemporal dementia. And we have Korsakoff syndrome secondary to chronic alcoholism. And we continue with other type of dementia. This process of dementia is characterized by stages. We, in daily language, at the level of clinical practice, we divide an initial stage, a moderate central stage, and an advanced stage. In general, each one of them take approximately 3 to 4 years. And the average of life for the individual with a diagnosis of Alzheimer from the early onset to death vary between 9 to 12 years. I have patients that are with me for 15 or 16 years. But this is an average. In general, for any type of dementia, the initial stage is loss of memory. Together with losing memory is coming confusion, disorganization, some repetition, pay attention asking the same question, as well as telling you the same comment. They repeat with frequency. And they ask a question because they don't have capacity of retention of the answer that you give to them. At the end of the initial stage, individuals have more disorientation, Sometimes they get up during the night to use the bathroom, and they have difficulties after they turn off the light to find the bathroom and to return to bed. Sometimes they find themselves walking around the house, not knowing exactly where they have to go, because it's a process of disorientation. Some irritability occurs on the initial stage based in the almost desperate feeling of the patient, not knowing or not being able to describe clearly what is going on with them. Therefore, there is a lot of sadness, anxiety, some fear, and some anguish, all together creating those stages that are very difficult to manage. When we walk into a moderate stage, situations change, get more complicated. There is a peak of behavioral disturbance. This might be at the level of more depressive episode, more anxiety, feeling of panic, resistance, more difficulties with personal hygiene, some of them lacking appetite, and others becoming partially psychotic with visual hallucinations as well as delusion. They become very paranoid. They make accusatory comment to caregivers or to the wife or husband. As a product of becoming paranoid, they become easily agitated and sometimes dangerous based in being able to lose control, to hit someone or to charge over someone without even knowing what is going on. The moderate stage in the United States is the stage that produces the higher number of members to be placed in supervised environment. From the moderate stage, is the number increase for assisting living unit placement, as well as nursing home placement, as well as memory unit placement. All of them because it's an station which one mark well the lack of function of individual, the almost impossibility for family members or caregiver to continue monitoring safety, this type of behavior without getting into bigger complications. Individuals, they stay home during the moderate stage. At the end of the stage, start declining in every level of function. They recognize probably one or two persons, the closest one. They start having difficulties with motor function. They adopt a more fetal presentation with their body, with a curved back. They have very unsteady gait and they fall frequently. Sometimes become agitated, but most of the time they sleep very long and they don't respond to interactions, more difficulties for nutrition, and more difficult for how to medicate them when they refuse to swallow and they become very, very agitated. But this is an overview of the stages this we can use to describe any type of dementia. And then we will be a little more specific when we kind of express what are the difference between one and other, but in specific areas. With this, Evelyn, I would like to invite the group to participate, and please, with questions, because we are in time to take a good piece of time and to chat about any question. We have a good audience, therefore I am expecting good questions.
Thank you so much, Dr. Praderio. And I am sure, I know I have questions, and I'm sure there are many in our participants. And I want the participants all to know that you are welcome, if you're on Zoom, to either go to the chat room, you can unmute yourself, you can put your hand up. If you're on the phone, I have a little website and I can see that you have unmuted yourself, and you can do that by pressing *6 on the phone, and I will call upon you with your area code and prefix if necessary. And we really want to hear from you. So please go ahead, start asking us questions. And I've got Michelle Sanford.
Yes, I have a question. Doctor, is there a specific doctor that can diagnose each one, or is it like a primary care doctor?
Well, this is dementias and cognitive disorders are being covered by two specialties. One is neurology doctors, and the other is neuropsychiatric doctor, both with the ability to diagnose, to manage, to do workup, and to give you more clear idea what is the origin of the dementia. Those two specialties are dedicated to those type of diagnosis.
Thank you.
You're welcome.
Okay, Nancy.
Okay, doctor. Oh, am I not on mute anymore?
Okay, sorry.
Phyllis,
is that you now?
This is Phyllis, yes.
Takeda Jackson is asking me
Okay.
if I ever experience a dementia this reverse, a dementia this from having the diagnosis of the dementia, then someone correct the symptoms and get cured or return to normality. And the answer is yes, Takida. There are 2 or 3 dementias that are reversible. If you are lucky in diagnosing them appropriately and treating them appropriately. And I will share 2 with you. One is lack of vitamin B12 make you demented. But in 3 or 4 months of correcting the level of B12 by injection, good nutrition, you improve the cognitive functions and return to normality. The second one I will share with you is dementia secondary to hydrocephalus. This is a collection of fluid inside your brain, creating compression and deteriorating the cognitive function. If a neurosurgeon operates you and put a shunt connecting the brain with the GI system, the fluid will evacuate. The brain will recover function, and in about 1 year, you will be back in a normal cognitive function. Those are called reversible dementia. Question from Grisel. Recommendations and way to diagnose Alzheimer and dementia, and where to start. PCP, neuro. Honestly, Grisel, I always suggest to start a conversation with a primary care physician. I know that they don't like very much to do a workup, but in general, you can have a conversation and the conversation end up and they may refer your family member, your mother, your father to another doctor. And like I shared before, the doctor who manage those specialties are neurologists, and we, the geropsychiatrists, one. But involving the PCP is very important, Grisel.
A lot of times they provide support for the caregivers too.
Yes.
Because they know the local resources maybe better than, some of the specialists.
Yeah. Late is question, what recommendation for memory loss from alcoholism other than stop drinking? Well, I think late you asked the question and you kind of answering the question. Stop drinking will be the first step, and to do a good detoxification and helping the patient to recover some nutritional losses, because in general, chronic alcoholics have deficits of thiamine and other vitamins, and those have to be repaired. A little difference, memory loss is the memory loss of the alcoholic. Chronic alcoholics have intermediate memory loss. Therefore, they remember what they ate for breakfast. But on the other hand, they maybe forget intermediate memory. For example, what happened 6 months ago, or what happened 5 years ago. And that's the reason the two covers their lacunar areas, meaning the emptiness of those areas. They confabulate. They make things up, and sometimes very humorous, very, very humorous. They are pleasant. They talk your head off, telling you things that are not true. But the best thing for chronic alcoholism is to treatment, to stop drinking, to good nutrition, and to help them to. We have a term in medicine, and it's how long will take the brain to dry after you remove the alcohol. Because years ago, they will call them wet brain, the alcoholic. Therefore, how long will it take to dry? Well, I see my patients free of alcohol recovering function slowly up to a year, year and a half. Therefore, you have to be patient.
Okay, Phyllis, you've been waiting.
Yes, I have.
Thank you.
Okay, I have a few questions. The young lady, Takita Jackson, that's my niece. I gave her the website. We are on here. It's her grandmother, which is my mother. And we're just trying to get some answers, to maybe try and help her more. The doctor was saying about the B12 is something good for her if she has a lack of B12. I was wondering, should it be the B12 drops or the pills? Which one would be best, and what milligrams would be good for her to use?
Well, with all of my respect, I will give you a part of an answer because I do not want to prescribe and treat during the time that I am doing a presentation. But with all of my respect, B12 are coming in different form. And you will be good if you obtain the one who have the easy absorption. Therefore, the best will be to have a shot a month of 1,000 microgram or 2,000 microgram. Then the second best absorption is the sublingual liquid, when a little pill formed that dissolve under your tongue.
Right.
And the worst, the one who take longer and get lost, is the pill because have to go through the GI tract. And the absorption is less serious. Well, thank you for your question.
Yes, sir.
I am continuing here because I have homework to do. What are the most common symptoms of hydrocephalus? Mary Lee, the most common symptom of hydrocephalus is memory loss. You come to the doctor because you get confused and because you are having memory loss and you are misplacing things. But when you show up to the doctor, you already come with two other symptoms that the doctor say, wow. And those are ataxia. Ataxia is walking with your leg separated and very slowly. And the third symptom is urinary incontinence.
Mm.
Those three packages of symptoms define the possibility of the hydrocephalus that you need to confirm with a CAT scan or an MRI. When you have confirmation, you invite a neurosurgeon into the package of treatment, and they are the one, if they consider this is a hydrocephalus and need treatment, they are the one who do the shunt. And honestly, I have about 5 or 6 on the last 10 years. The initial shunt, all of them work well, and we are super happy. You won't believe, patient and family. 2 of them got a block shunt 2 or 3 years later that they stopped functioning. And therefore, they return and they reshunted and they are doing well. Therefore, it's an okay therapy, work well. We moving here with another question. Let me see.
Yarlin, you've been waiting a while.
Let me see. Thank you. I know that the blood test could show you B12 level, but how would you suggest that a patient be tested to see if they have fluid on the brain? Oh, Well, fluid on the brain is the hydrocephalus, and I already shared 1 minute ago how to make diagnosis and how to work with the hydrocephalus. Do you find family history a good indicator of getting dementia or Alzheimer? Well, family history is very important in familiar Alzheimer. It's something that have an early onset. Overall, other type of dementia have certain degree of continuity and familiar form. For example, Parkinson might be one of them. And there are some correlation in Lewy body dementia. But if your fathers were having cardiac problem, hypertension, high cholesterol, and vascular dementia, if you are healthy, not smoking, not drinking, not having high cholesterol, exercising, I think you will beat the hereditary component of vascular dementia just by decreasing the risk. When you make reference to a workup, what exactly is included in that? What will an initial exam with a neurologist consist of? I will clarify, I am not a neurologist, but I share with Teresa in 1 minute what is a workup. The patient came to me for the first time. Prior to this, I collect information from primary care physician, all of medical information that we can have around us. At the time of the patient coming to the office, they visit with one of my nurses. They have tests of memory. They have an interview with them and with the family specifically because we take it very much into relevance. Then the patient is seeing me. And at the beginning, they see me by itself, and then I ask permission and we incorporate the wife, the husband, the children, and they have a conversation and I collect information. As soon as I reach the point of move toward diagnosis, I start with everything that I request. I request regular blood work with emphasis on cholesterols and triglycerides. I ask a level of B12. At the same time, I am asking for a CAT scan that I will read. And if they have a CAT scan done 1 year before, I don't make this costly. I try to collect the CAT scan and reread it and find out what is the condition. Very clear, Teresa. A CAT scan or a MRI is not going to tell my mother have Alzheimer. The CAT scan or MRI we use to remove and to rule out other process. In general, the Alzheimer's disease CAT scan look very atrophic, shrink brain. But when I ask for a CAT scan, I want to be sure that she doesn't have a tumor, that she doesn't have a meningioma, that she don't have a hydrocephalus, any other factor that may be influential and at the same time may be cured by my intervention. With this in mind, there are few cases that my workup include psychological testing. In general, Teresa, those will be the cases when I have to end up going to court and to testify of patients they are demented and they were signing a will or creating other problems that complicate the situation. But in general, those are more or less the different steps of a workup.
Do you use PET scans, doctor?
PET scan in specific occasions. You need to do a complete workup, including psychological testing for Medicare to pay for. In PET scan diagnosis just two disorders: Alzheimer's disease, dementia, and frontotemporal dementia.
Thank
Dr.
you.
Praderio.
Very,
Where?
very active audience. Very happy of
Great.
you with your questions. I think this is the way I believe that we should be working on the future, because really you can air up your concern and ask your question and fortify what you already know.
Was that you, Phyllis?
Yes, it was. I was gonna ask the doctor, where are you located, doctor? Are you taking new patients? And if not, would you recommend anyone in the Arkansas, Tennessee, Missouri area?
Oh, well, I am located in Corpus Christi, Texas, by the water.
Uh-huh.
And I know I am a member of the American Psychiatric Association, and I am a member of the American Geriatric Psychiatric Association. I will suggest, man, that you communicate to the American Geriatric Psychiatric Association and ask this if they can give you the name of geropsychiatric doctor in your area. We are not many around. No, in South Texas, we are just two, one in I think one is on the south, on the valley, and me here south of San Antonio. But that will be a good way for you to receive the name of who is around your areas.
Thank you.
Dr. Praderio, I hate to do this, but I feel like we should stop because I've got two announcements to make for next week. And gosh, I have like 4 questions I'd like to ask you, so I hope we do this one again. Anyway, I want people to know that if we're going to send you some resources along with the slideshow that Dr. Praderio just gave us, and I took some good notes. I hope you were able to do that too. And if you did not register for the session today, if you got the number or the link from a friend or one of your senior centers, you please call and register, because that way you will get the resources and you will get the slideshow and you will also get the monthly calendar. And the way to do that is by calling our wonderful Minerva at 866-390-6491. That's 866-390-6491. And in addition to that, I want to tell you about 2 upcoming sessions that we still have left this month. One is next Tuesday, March 26th, Beyond Burnout, Nurturing Resilience and Caregiving. And this is going to be an interesting one because this PhD, Lakeland Eichenberger, is going to give us tips on how to take care of ourselves, tips and techniques and tools on how to keep from getting into burnout. We also have a special one that's been added to the calendar that you may not have, you probably don't have. Now that's on March 28th, and it's a Spanish presentation. It'll be all done in Spanish. The speaker is Maria Wachter, who was at the Spanish Aging Summit this year, and it's on the techniques of relieving stress and getting centered. So those are going to be very interesting presentations, and I hope you will join us again. And thank you all so much for your attention, for your participation, and for your caregiving. And Doctor, you're always fabulous. We love having you here.
Thank you, Helen.
Yes, and I think you're
Thank
right.
you.
We learned so much from them during the question and answer session. It's so great for us.
Thank you, thank you.
And I'd also like to thank the WellMed Charitable Foundation for all the support that they're able to give caregivers and have for so many years now. And with that, I'm going to close this, and I just want to say goodbye to everyone. To stop the recording, you will hear a little announcement, and I hope that we see you again very soon. Bye-bye now.